Much for joining us today for our webinar. My name is Janina Krumbeck. I'm the Director of MiDOG Animal Diagnostics. MiDOG is an independent testing laboratory within a CLIA certified facility in Tustin, California. And what distinguishes MiDOG is that we employ state-of-the-art molecular-based next-generation DNA sequencing as a diagnostic tool across various sample types and animal species. With the all-in-one test, MiDOG excels at delivering advanced diagnosis for infectious diseases for all animals, offering a swifter alternative to culture and sensitivity and a more comprehensive approach than PCR. We do have two co-sponsors for today's event. The first one is the Southern California Veterinary Medical Association, or short the SCVMA. The SCVMA is the nation's largest veterinary medical group. And if you're a veterinary professional in California, I would highly recommend joining the organization. And the third sponsor is the Animal Dermatology Group. These board-certified dermatologists at the animal dermatology clinics are global leaders in the research, diagnosis, and treatment and education of dermatological conditions affecting pets, and have pioneered cutting-edge treatments for allergic skin conditions, ear disease, food allergies, and other acute and chronic skin disorders affecting dogs, cats, and horses. Today's webinar, we will provide 1 CE credit to all veterinary professionals. To receive your certificate, please follow the link posted in the chat, and there will also be a QR code at the end of the presentation that you could use. We will have plenty of time for questions at the end, so please enter any questions or comments you may have in the chat. And with that, I'm getting to today's speaker. Today's speaker is Dr. Rosenkrantz, a diplomat of the American College of Veterinary Dermatology. Dr. Rosenkrantz is a graduate of the University of California, Davis, and completed his residency training in private practice. He's a past president of the ACVD and is co-owner of the Animal Dermatology Group, with locations throughout California, the southeast of the US, as well as Perth, Australia. He actively trains residents in his ACVD-approved residency training program and participates in clinical research trials. He has published many articles and book chapters on small animal and equine dermatology. He's a recognized national and international speaker on veterinary dermatology and was awarded the DVM Pharmaceutical Award of Excellence and the Frank Kral Award for his contributions to veterinary dermatology. The title of Dr. Rosenkrantz's talk today is Methicillin-Resistant Pyoderma and How to Deal with This Emerging Problem. So Dr. Rosenkrantz, please go ahead with your presentation.
Great, thank you, Janina. And again, I'd like to thank the SCVMA and MiDOG for sponsoring the webinar today. I also need to disclose that I do serve on a number of advisory boards, some of which companies will be talked about today. And probably most importantly, in regards to the talk today, is that I do serve as an advisory board member for the MiDOG laboratory. I'd like to also give recognition to our animal dermatology group, and as many of you probably are aware, our group has grown and expanded. It's predominantly has a strong presence here in Southern California from where I'm at, but you can see there are a number of other states and locations where we have grown to, and I will acknowledge in advance many of my other colleagues and residents. If I don't acknowledge your participation in the lecture as far as slide material, I want you to know that some of the slides that I may present today have come from some of my other colleagues. I'm very happy to also mention that our group has a formal dermatopathologist in our group, Dr. Kelly Keating, and who's now doing the majority of the dermatopathology services. Kelly's one of 3 diplomats that's double boarded in pathology and dermatology, so we're extremely lucky to have her as part of our group and really has excelled our dermatopathology services. And then we also have another division where we supply allergens through the animal immunotherapy services for those veterinarians that utilize the VARL. So let's jump into the topic. We have a lot of material to cover for 1 hour, and this is a difficult topic to really do justice in 1 hour, so I'm going to do my best to highlight things. I think everybody that's in attendance is well aware of the emerging problem of methicillin resistance, and it's a problem not only locally but internationally. Here in Southern California, unfortunately, there isn't a day that doesn't go by that we don't see a MRSP infection. So there's lots of different people on the webinar today. Some have a great deal of experience in dermatology, and then others may, just sort of dabble with it or have special interest or GPs. So we're going to try to, have our presentation geared to address the spectrum of the level of experience. Because the topic is so large and many areas can't be completely covered, there's two references that I like to cite in regards to methicillin resistance. One is a paper that's several years old, which is the Guidelines and Diagnosis of Antimicrobial Therapy for Superficial Bacterial Folliculitis. Dr. Hillier and others listed here, a very prestigious group of dermatologists, microbiologists, and pharmacologists contributed, and it's a very good review. And then in more recent years, the clinical consensus guidelines, which are a series of guideline papers that are published in support with the World Association of Veterinary Dermatology. And one in particular from 2017 really addresses methicillin-resistant staphylococcal infections and gives you sort of short little keynotes regarding specific topics on diagnosis and therapeutic and preventative measures. So we are going to talk predominantly about staphylococcal infections and most notably staphylococcal pseudonephritis or the resistant form of that, what we call MRSP. I am going to talk a little bit about the differences and similarities of MRSA versus MRSP, and we need to make sure that we are clear in our distinguishing discussions with clients regarding that. We have a lot of veterinarians sometimes tell their clients that their dog has MRSA, and that is extremely rare in dogs and cats, and we will try to attempt to clarify that. And we're not going to talk much about some of the other less common causes of folliculitis. So the idea would be to go through and give you a little background on staph itself and resistance, the difference between MRSA and MRSP. We'll go through clinical signs and focus on diagnostics, and then when we get to therapy, we're going to talk predominantly about topical therapy because that's really where some of our emphasis is going with staphylococcal resistance. So many of you probably are very familiar what is methicillin resistance, and this is when staph acquires an altered penicillin binding protein 2A, and then it renders the staph resistant to methicillin. Of course, we use oxacillin on our traditional culture and sensitivities to equate for methicillin resistance. This resistance can be predicted by the staphylococcal chromosomal cassette mecha gene, which is the gene that encodes for this penicillin binding protein. And over the years, there have been many different mecha genes that have been recognized that give rise to different forms of methicillin-resistant Staph aureus. Typically, in humans, it's divided into two major categories, hospital-acquired and community-acquired. And each of these have various subtypes. Hospital-acquired MRSA is typically known for being more drug-resistant and referred to as types 1, 2, and 3, or common names of USA 100 and 200. And then community-acquired, which really developed from hospital-acquired, these are typically types 4 and 5, or common names USA 300 and 500. And although these may be more antibiotic responsive, they often are associated with more nasty exotoxins that cause more damage to tissue and more tissue necrosis reactions. So they have more of a virulent course. I show an image here of a tie because ties really at this point are been banned from most hospitals. These over years, there have been reports like in the New England Journal of Medicine where ties can be contaminated with MRSA. And you can see as a doctor would come in and check a patient in bed with an IV intact as this contaminated tie might drag across their IV and contaminate their patient with a MRSA infection. Community-acquired strains of staph are not uncommon to be picked up in places like public gymnasiums and workout equipment. So those of us that like to exercise, there is some madness and method to wiping equipment down and disinfecting it before you use it or after you use it so that we don't potentially spread things like MRSA amongst the common gymnasium areas. So just a couple of examples. So MRSA is really primarily a human pathogen. Uh, it can be isolated as a carrier state in nasal passages of people that are carriers. And as I mentioned, it originally started as a hospital strain, and now these community-associated infections have emerged. This is a human pathogen. So when you use the term MRSA to your veterinary, clients, you got to be careful about that because people freak out because the typical, courses of what happens with MRSA in humans, where there can be people can die from these types of infections or have substantial tissue loss or amputations when infections are really bad, aren't the types of things that we want to alarm our veterinary clients about. Now, we do know that colonization of MRSA can happen in healthy dogs and cats. So they can actually harbor MRSA but have no disease from it. And this is strains like the USA 300, for example. And when we talk about large animals like horses and livestock like pigs, they can have other strains that actually were originally found in humans and then mutated and became more of a source of infection in horses and pigs. And so in this situation, the equine practitioners and those of you that do any food animal, particularly working with pigs, may have a little bit more of a zoonotic concern regarding this. There are a number of publications out regarding outbreaks of MRSA in nursing homes, convalescent homes. And we know now that companion animals are quite valuable for a lot of these elderly patients. But there have been studies where MRSA outbreaks have occurred in convalescent homes and nursing homes, and they've treated everybody with whatever drugs necessary and eliminated it, and then the problem relapsed. And what they found is that some of these visiting animals were harboring with no symptoms whatsoever MRSA, and then they were giving it back to the nursing home patients. So it was kind of facilitating relapses in the nursing homes. And there's many, many publications that list potential pet, animals as reservoirs of spreading methicillin-resistant staph in human health situations. So it would be extremely rare for a dog or a cat to have a Staph aureus infection. It can happen in rare occasions, but mainly these animals might act as vectors or sources to recontaminate humans. And as I mentioned, if you're an equine practitioner, because the strains of the equine staph actually originated in humans, there's a little bit more of a concern about zoonotic recontamination back to people. So those of you doing equine medicine should take more precautions as a rule. Similarly, this would probably not be a scenario where you would want your child going up and giving a pig a big wet kiss on the snout. If you were the veterinary owner of this child, you might be yelling out in your own mind, careful, you could get MRSA sequence type 398 from that pig. But then if you were the pig owner, you might say, hey, careful, that child might give my pig MRSA. So again, the concept of contamination and cross-contamination can exist. So what about MRSP? This is the one that we want to focus on. This is our big concern. It is a big, huge problem here in Southern California and many of our other specialty dermatology practices throughout the country and the world. Certain places in the world do a better job with minimizing antimicrobial use, and so they have less issues. Some of the Norwegian countries do much better at minimizing antibiotics and hence have less problems with methicillin resistance. But this is predominantly an animal pathogen, although humans, both veterinarians and say owners that have a MRSP dog in their household, you can isolate MRSP from humans, but again, not typically associated with clinical disease. So much like dogs and cats can harbor MRSA with no clinical disease, some humans in the environment around dogs that have MRSP can actually harbor and carry MRSP. In fact, some surgeons that may culture positive could potentially contaminate dogs or surgical sites, for example, with that. Now, this is not to minimize the possibility of a sort of an emerging or underestimated zoonotic pathogen, although I think that this publication overemphasized that concern. But there have been some reports of humans that have developed staph pseudonemesis infections. The first case that was reported was in 2006, and I believe it was in a patient that had a major orthopedic surgery. And so this is a potential pathogen that could be passed to people and cause clinical disease, but it is extremely rare for that to happen. And in most of the cases, there's usually an immune compromised individual that would develop such a complication. But I refer you to this review article for those of you that want to read more, but I don't typically get my clients all worked up and paranoid because their dog has a MRSA infection. We tell them to take basic precautions, which we'll get to as we talk throughout the lecture. A couple other terms to be familiar with, multi-drug resistant staph. So this would be a staph that's expressing co-resistance to at least 2 additional antimicrobial classes. So this is a term that's now being used. And now we have even an additional term called extensively drug resistant. And this is if the strain is non-susceptible to all but maybe 2 or fewer antimicrobial classes. And unfortunately, in our practices, we're tending to see more of these extensively drug-resistant staphs. This is a culture that I had just literally last week from one of my patients. And you can see the degree of widespread multiple class resistance throughout. So these types of infections where they used to be very rare, unfortunately are more common. And so this is a concern and certainly frustration as we're trying to manage some of these cases, because as we'll talk towards the end of the lecture, when we have to reach for antimicrobial selection, some of these drugs that we're forced to use, drugs like say amikacin and rifampin, these are drugs that require more monitoring and more care when we have to reach for such drugs. So since we don't necessarily have interaction here on this webinar, I'm going to cut to the chase on the answer to this question. But when you look at a clinical case of a pyoderma, can you look at lesions clinically and be concerned about methicillin resistance by the lesion itself? And both of these are nasty inflammatory pyodermas, but we cannot tell which one is the methicillin resistant. That can't happen unless we actually do a culture and sensitivity. So that's where we, often have to reach for cultures for more information. So I'm going to share with you a couple of follow-up studies that we did many moons ago. I did it originally in 2012. I looked at the incidence of MRSA in our canine pyoderma population, and we looked at 190 cases, and we had 49 or 26% in 2012. And then Dr. Muse said, well, 2 years later, let's repeat that because we were starting to see a surge of resistance. And not only did we see a higher incidence of 60%, but we also saw that a number of our antimicrobials that previously were exhibiting high degrees of efficacy were also dropping. So you see that chloramphenicol, for example, went down from 85% to 60%. And minocycline dropped from 70 down to 50, and clindamycin dropped from 40 to below 30. And so, you see that we're losing antimicrobial selections as well, besides the incidence going up. I pulled this paper from 2021, and it doesn't really show a much higher incidence of MRSA than what our study showed in 2012. But when you pull the references from this paper, most of the references were actually, somewhere between 2010 and 2014. So they really weren't reflecting updated information. And I would tell you, and I have not looked at numbers, but it would not surprise me that in our clinical practices, now we're, have we gone from 60% to above 70, 75% of the staffs that we see are more likely, MRSA infections. And so that probably needs to be updated in our clinical practice, but I know for a fact that the incidence has gone very, very high. And so this is obviously of concern, and we get very worried about when we don't have great antibiotic selection. Now, there's lots of different presentations of staph pyoderma. I mean, everybody knows what a pustule looks like. And so, hey, when we see these, we get all excited because we can't wait to do cytology. And a pustule like this gets our eyes open up where clients are grossed out. But as dermatologists, we get very excited. And then what you have to understand with staph folliculitis and pyodermas is there's a lot of different spectrums of activity. Now, most of us are going to still recognize lesions like this that have circular scale and crust and erosions to be associated with a staphylococcal infection. So that's not too difficult to determine. But sometimes these lesions get burned out and you get left with just sort of dry scale and crust. Sometimes, like in a case like this, you might still see a pustule. And you can sort of tell the owners it starts as a pustule, but then it proceeds through these various stages where ultimately you may be just left with sort of a fading erythematous circular lesion. And many times the pustules are gone and we just have patchy areas of alopecia. Sometimes the sites will hyperpigment in the center, and that's a post-inflammatory change. And owners sometimes get paranoid about dark patches. So areas where previously you had active infection, it's very common for melanocytes to be stimulated, and we see the hyperpigmentation as part of this sort of transition of the pyoderma. In other cases, we just see areas of patches of alopecia, maybe some light scale. So we have to be aware again that this probably at one point was a pretty hot folliculitis, but as time's gone on, it causes just alopecia. In this Dalmatian and another short-coated breed, sometimes we're just left with patchy areas of alopecia, like a moth-eaten appearance. And there may be some mild scale or residual inflammation left, but we need to know that this is still a footprint of what a previous folliculitis was doing. In other cases, they look more angry and we get more nodular reactions. And in situations like this, there's typically a folliculitis and a furunculosis, where the hair material ruptures below the surface and it creates this sort of pyogranulomatous reaction pattern. And we get this very lumpy nodular appearance to the lesions. Sometimes you can squeeze on these and you can get some type of sort of hemorrhagic, deep purulent exudate to come up from the lesions. But again, here's a dog that's just scaly and dry that was immune compromised. And you'd look at this and you'd call it, well, is this a Seborrhea Sika dog? Well, this is probably a dog that had a burned out folliculitis. And if we were to do cytology from this scale, it would not be unusual to find bacterial overgrowth in a situation like this. And then we have all the various fold dermatitis lesions, so the tail fold, lip fold, vulvar, the pedal, facial fold. And then we have the French bulldog, a disease that was turned into a breed that we see, unfortunately, on a daily basis. But many, many of these dogs, of course, have ongoing allergies besides anatomical fold problems that create an accumulation of bacterial overgrowth and infection. Another case was more of an angry, deeper infection. Some of these are complicated with scar tissue. When we biopsy these, we'll often see granulation scar tissue with small fragments of keratin material that elicits an ongoing nidus for infection and foreign body reaction. Here's a bull terrier or Staffordshire Terrier cross that's complicated by a solar dermatitis. The solar component causes thickening and entrapment of the hair follicles, and they blow out below the surface and they get very nodular draining reactions. You can tell there's a solar component because you see in the center here, this pigmented area is non-affected. So the pigment of the skin has protected the animal from the UV damage, and that area is normal. And the adjacent areas that have no pigment are thickened and inflamed and infected. Cytology, I mean, some days I count how many cytologies I do. Like yesterday, I had a big plate of leftover slides. There's probably 12 to 15 cytology samples I took in just one day. And this is such an amazing, informative test that allows us to determine immediate ideas of infection, drug selection, allows us to monitor cases, determine what we may need to do. Maybe this dog had more staph initially, and obviously at this point he has tremendous Malassezia overgrowth, and so we often have to address things. So very, very important, valuable test to give us really a very spot check of information, often done in conjunction with cultures and sensitivities, but we can pick up loads of information. Here you've got, Malassezia and cocci, intracellular rods in this structure. Here's an eosinophil that has an example of phagocytosis of staphylococcal organisms intracellularly. And here we have a fungal hyphae that we detected on a cytology. So the information that can be gleaned from this test is really unlimited, and it's something that is done with a very high degree of frequency. There's lots of different techniques on how to take cytology. Like vets often ask me, how do you do it when you don't have a pustule or a papule? This is a dog that just sort of had erythematous scale, and you can see we just take a glass slide, and we're going to impregnate that slide onto the surface of the skin and get a sample in that capacity. We usually heat fix. Again, you're not going to have a barbecue with this. You don't want to overheat. You can use a lighter or a match. Just lightly heat fixation I find to be valuable, and then we go through our typical diff quick staining. And how you read slides, this is an image of, an image of a cytology slide that we're beginning at low power. And this is what I always encourage veterinarians to do, is to attempt to look at the slides under low power and then move the slides up in higher capacities. So looks like we may have a little bit of a weak signal here, so it's not playing the video very well. But this is in a higher magnification here. And then as you go up in magnification, ultimately what you want to try to do is get to oil, because under oil immersion is when you're going to be able to see the extracellular and intracellular bacteria. And you can see here a variety of different rod-shaped bacteria with neutrophils and macrophages. So sort of a pyogranulomatous inflammatory response. So what about cultures? I'm often asked, when do we perform and do cultures? Typically I'm looking at history on a referral basis, and I've looked back through and I see that maybe beta-lactam antibiotics have been used and have been ineffective and dosed properly. In my own cases, if I'm seeing new lesions after 2 weeks of antibiotics, I get concerned, and that culture would definitely be indicated. Is there the presence of residual lesions after 6 weeks, where you're seeing coccoid bacteria cytologically? Are there intracellular rods on cytology? Is there a history of another dog with multi-drug resistant staph in the household? Could that be a concern where it could be passed, say, from one dog to another, although that's not as common as one would think? A lot of different techniques to take cultures. Obviously, when we have a pustule like this, we might sort of drip a little bit of alcohol, allow it to air dry and open up that pustule, and then touch our pipette to that lesion. When we have crusted lesions like this, we often will lift up and avulse the crust and culture underneath. And then a lot of times when we're taking biopsies, we may actually take a tissue section and do a full sample that could be emulsified at the microbiology lab and have a tissue culture performed. This is an example of pulling back a crust that was very adherent to an underlying eroded ulcerative lesion, and then just taking your culturette tip and getting your sample in that fashion. So I'm not going to go into all the details about culture and sensitivity. I think we need to, be aware that there are published protocols and methods of sensitivity that have been established by the Clinical Laboratory Standards Institute and the Veterinary Antimicrobial Susceptible Testing. Most of us are very familiar with the breakpoint of the minimum inhibitory concentration to kill a particular bacteria. And those are the most common sort of reports or breakpoints that are given with most traditional cultures and sensitivities. In the human field, and it's emerging into the veterinary field as well now, is another breakpoint called the mutant prevention concentration. And this is another level of a cutoff that is not only killing, should we say, susceptible bacteria, but also eliminating first step resistant cells. And you can see in this schematic from Dr. Blondeau's paper that here's your MIC level, serum concentration of your antibiotic here, and somewhere between the mutant prevention concentration and the MIC is this mutant selection window. So this is where we start to have problems with some of the bacteria that persist and mutate and then create further resistance. If we can hit bacteria at the mutant prevention concentration initially, then we're killing not only the susceptible bacteria, but those that are likely to become resistant strains. And so MPCs are now being seen in more of the human sensitivity profiles to help minimize the development of future resistance. Some of these are being established for veterinary medicine as well. So the neuroculture technique, to talk just briefly about the next generation DNA sequencing, this is a molecular-based test that detects all microbes by way of DNA extraction and sequencing. And this is something that has been very well established in human medicine for an extended period of time. So the human microbiome is a really fascinating area and above and beyond what we can talk about today. But this little slide just to show you all the different various parts of our body and what are normal microbes in certain areas on your forehead, your arm, your ears, and anywhere else, they all vary. And then on top of that, there are differences based on age. There are differences based on race. There's differences based on your immune susceptibility, the drugs that you're on, what medical conditions that you have. And so there's so many variables, but the human microbiome is very, very well established. And now, thanks to companies like MiDOG, we have this huge, canine microbiome that allows for determination of what are normal bacteria and yeast and fungi on various parts of the body. Now, we have a lot of different information based on breeds, but there's a lot of studies that have come out that shows differences anatomically from different regions, and this is being further evaluated on a daily basis. We're adding to the microbiome determination. And by knowing what's normal, then that allows us to determine what is abnormal. Now, the MiDOG technique, it utilizes a culturette that's a sterile. You rub it vigorously on a site or stick it into a purulent area, and then it's put in this DNA transport media, and then it goes to the lab where the bacteria and fungal DNA extraction and sequencing takes place. And then you're isolating all at one time bacteria, fungi, yeast, so that we actually get a report of what's going on in that particular section all at one time. And as I said, we know what normals are. So there's thousands and thousands of normal dogs, and then we can compare and contrast that to disease samples so that we can compare the normal and abnormal. And often a lot of the animals that we see can have mixed infections. So these infections can contain multiple different organisms. And what I like about the MiDOG is it actually gives you a percentage of what we're seeing, regarding the types of organisms that are present all at one time. So we get like a report of 90% MERS-P with 10% strep, or 60% Malassezia and 30% Candida. The other things that's really great about this is you can actually isolate pathogens in disease samples. So like biofilms, for example. So like here's a fairly nasty looking Pseudomonas otitis with this stringy purulent material coming out of an ear. And we know that biofilms protect bacteria, and it makes it very difficult sometimes to get a true isolation of the infectious organism. But with this DNA sequencing task, we're allowed to be able to identify the bacteria in the biofilm. The other benefit is the determination and isolation of hard to grow and isolated pathogens. Things like Mycobacterium and Burkholderia, for example, can sometimes be difficult to find on routine cultures or misdiagnosed. So cases like this cat with Mycobacterium that had failure of isolation on routine cultures was identified on a MiDOG culture. I show you Cooper just because this one is sort of very fresh in my mind because the paper just got accepted to the Vet Derm Journal this last week. But Cooper was kind of a cool case, really nice dog. He came to see me with a history of autoimmune hemolytic anemia that was being managed with prednisone and cyclosporin therapy. And then he had developed this non-healing wound on his paw. It had been previously cultured and was isolated from the culture and sensitivity report as a Pseudomonas species. We followed up with MiDOG next generation sequencing, and we actually isolated Burkholderia, which is an opportunistic bacteria. But very interestingly, in this particular case, this Burkholderia, which you can see the rods here on the cytology, ended up being a completely different species that had never been reported yet in the dog. And we went on further to confirm that this Burkholderia gladioli was also documented with PCR. So we confirmed it not only with next generation sequencing, with also PCR. And then we treated Cooper with marbafloxacin for several weeks, and he improved dramatically. Of course, we also reduced some of his immunosuppressive therapy. So things like this are not possible without the science of newer technologies like MiDOG. And so we're looking and utilizing MiDOG more and more, not only on our just everyday cultures, but particularly for those where we suspect more unusual opportunistic infections. Okay. So that brings us to therapy. And as I always tell all of my clients, they come in with a history of, say, a MRSA infection, and everyone's focused on that as the primary diagnosis. Well, in my opinion, primary pyodermas, they just don't exist. There's always a reason that there is an underlying infection, and that's what owners have to understand. So sometimes they're like, even my chronic cases, well, he's better on antibiotics, and we go off antibiotics, or we quit doing our topical therapy, and then it comes back again. Why is that? Well, that's because we haven't, identified and controlled the primary underlying disease. And in clinical practice, the number one cause for that is allergies. And this isn't going to be a lecture on allergies, but we know that management of allergies is incredibly important to prevent relapses, particularly in the form of pyoderma. I don't have time to run through all the details on therapy, particularly systemic therapy. We're going to talk primarily about topical. I'll mention a little bit about systemic therapy at the end of the lecture. And not every client, is geared towards topical therapy. I tell some clients, well, we need to, bathe your dog 2 or 3 times a week, and they'll respond back, well, I don't even shower that often. So yes, I could detect that in the exam room. So topical therapy, we use it as a sole therapy or as an adjunctive. It can reduce the need or the duration of systemic therapy. It can be very helpful for our methicillin-resistant infections. In fact, sometimes that's our only therapy. It's very helpful for localized lesions. Early stages of pyoderma is probably where it's most effective and as far as elimination of infection. But we use it a lot as prevention for reoccurrence. And we also can minimize the concerns about cross-contamination of other pets in the household. But as I mentioned, compliance can be an issue. So here we have what the dog thinks he's a lap dog, but not really a lap dog. And it's a chronic atopic dog. And you can see excoriations, alopecia, some malodor, some evidence of papules in the intertriginous areas ventrally. So if I'm going to tell this owner, are we going to bathe this dog like every day or every other day? That's going to be a lot of work and very difficult. But even smaller sized patients sometimes can be challenging. So this happened to be a Pomeranian with Cushing's and allergies. And, I told the owner that we would want to try to bathe this dog more frequently. And she said, well, why don't you come over to the house and bathe him every day? So we can know that certain personalities, limitations of some of our clients, the topical therapy is not always a suggestion that's going to go over very well. There's a young Dr. Griffiths that is confused about what shampoos to pick and select because there are so many choices that are out there. And the nice thing, this is a photo from many, many years ago, but we have so many great products now and so many, different pharmaceutical companies that supply us with wonderful topical therapeutic agents. And I'll show you some of the ones that I use, but there are a lot of, products that have tremendous, equal benefits, and you have to sort of try to determine on your own and use products and sort of see which ones you personally like better. So I always bathe my own personal dogs with a lot of the new products that come on the market so that I can actually have firsthand feedback on how well does it lather? How does it smell nice? Does it leave the coat soft and shiny? Does it leave the coat dull and dry? I mean, these are some of the things that really owners focus on is the cosmetic results of a product. And topical therapy by most clients can be done, at home. We of course, now have new different delivery and vehicle systems that make for easier therapy throughout the week. But I still personally like dogs to be bathed at least once a week minimum. And now we have all these other residual products like rinses and mousses and sprays and wipe-ons that can be used in between bathing. And there are some of the companies that are advocating less bathing and more sort of delivery with these different products. So you pick and choose based on the case, the client, the lesions, what works best. Um, I do like the mousses a lot myself. I think that of all the sort of spot treatments, I find those the most cosmetically appealing and often can penetrate crusts and thick hair, easier to apply on intertriginous areas like the paws in particular. So is it so much important that we look at the brand of the product or more the active ingredients? And that's probably the most important, is to focus on what the active ingredients are in the products that you have in your clinics. And of course, chlorhexidine is considered a workhorse for bacteria and also is beneficial for malassezia. And there's a variety of other products that have action. Interestingly, most people think about miconazole as an anti-yeast agent, but there is data to show that miconazole, when combined with chlorhexidine, actually has synergistic activity for staphylococcal infections. So when we have chlorhexidine with miconazole, that can have an increased efficacy for staphylococcal infections. We don't use as many products with benzoyl peroxide as we used to. Benzoyl peroxide was sort of the product that, because of my age, it was one of the first antimicrobial products and had a lot of research done on its benefits for staph, and it still is very good for that. There are a variety of companies that make benzoyl peroxide shampoos, but it's an excellent follicular flushing shampoo. It degreases. So when I see a dog that is really greasy and oily, and I want to strip that grease and oil out along with controlling staph, benzoyl peroxide is really good. I also call it an excellent decasting agent. So here you see a close-up of a dog that has sebaceous adenitis, and it has those follicular casts, which are those little waxy nits that coat the base of the hairs right at the root of the hair. And benzoyl peroxide is really good at removing that. It's also very good at being comedomolytic, so it breaks up these comedomes as well. So some dermatologists have a little trouble with if the words have too many F words in it, like follicular flushing. One famous dermatologist that some of you may know, Dr. Craig Griffin, at a national meeting one time, he had a little trouble with one of the F words in follicular flushing, and he used a different F word. The audience was stunned, but didn't laugh initially until I started laughing, and then the whole group broke into laughter, and then Craig was not very happy with me after the lecture. But be careful. If you ever hear Craig talking about benzoyl peroxide, you'll hear him be very deliberate about the word flush. So a lot of different products on the market. They're all good products. I use all of these from time to time. Benzoyl peroxide can be a little more drying. Most of these newer products have moisturizing agents added into them to counteract the drying effects. As I mentioned, chlorhexidine is sort of the workhorse for staphylococcal infections. It's been shown in multiple in vivo and in vitro studies to have good efficacy, even for MERS-P, and it comes in all kinds of different delivery systems. And now everyone talks about it being non-irritating, and it is probably less irritating than benzoyl peroxide. But I'm going to tell you, over the years, with the increased use of this, particularly with some of the sprays and leave-ons, I've actually seen some contact dermatitises from chlorhexidine products. So you got to be aware that even though we're using these to help with infection, if a case is getting more broken out or having more of a reaction, I always warn clients about the possibility of products creating a contact dermatitis as a contributing factor. So again, less irritating than benzoyl peroxide, but still possible, create problems. And I generally like products that have at least 3% or higher. And there's a whole list of the products here, and I'm not going to run through all of them. But I've used all of these at various points in time. And if owners come in and they say, well, I've got one of these chlorhexidine shampoos, I'm not necessarily going to make them change over to one of the others. So lots of different products on the market that are available. We use a lot of trizchlor in our practice, a little bit of Meliseb, not as much as we used to. We do like Biohex, and we do use a lot of the Duxo S3 product that's currently on the market. So these are all just different options that you can pick and select from. Ophitrium is the newest ingredient that's sort of on the market. It's one of the key players in the new Duxo line. This is an extract from the root of the Japanese mondo grass plant. It has a lot of different mechanical, microbiologic, and immunologic functions. Microbiologically, it limits the adhesion and biofilm formation. It may restore protective balance of microbes. In other words, help to restore the microbiome when it comes to infection control. Lots of other products. We do use a fair amount of mupirocin for our MRSA infections, particularly for focal isolated lesions or deep walled-off lesions. It has a propylene glycol vehicle to it, so it allows for good penetration of, say, small isolated walled-off areas of infection. And then you have, like I said, all these other various products. I do like the mousses a lot. I think that for clients utilizing mousses as often, easily to apply and receive. Some of the hydrochlorous products, we'll talk about the Vetricin and others in a second. I'm not as big of a believer in those, although I have seen some cases respond to these. But I personally like dilute Clorox bleach better than the hydrochlorous products. I find those to be more effective or more responsive with Clorox bleach products, and we'll go over that here in a second. Here's a dog where we used Duxo mousse on a ventral cervical area. You can see inflammation and alopecia, and this is about 6 weeks later with just topical application of a mousse 3 times a week. Again, mousse sprays, wipes in between the pads of the feet. Facial folds often are beneficial with wipes so that we don't get excess product that beads up and gets into the eyes. So again, pick and select delivery systems based on individual cases and owners' requests. More and more bleach solutions being used in our practice. We use quite a bit. And this is this typical Clorox bleach, not the scented. This is extrapolated from use in human medicine and a product called Dankin solution, which uses baking soda to make the product less caustic or less irritating in humans. Dankins can be used in pediatric medicine to actually treat babies with staphylococcal infections. And the efficacy of bleach diluted rinses is more related to concentration and contact time. There's lots of evaluation. There's no great double-blinded placebo-controlled studies. The studies do suggest a minimum of 1 to 32 dilution. I typically do 1 to 10, and I find that it doesn't create a lot of complications with irritancy or excessive bleaching of the dog or burning sensation. There are reports, of course, of it drying out the skin. You do need to mix this up fresh, at least daily or a minimum every other day. It can be messy, and of course, it can stain, fabrics, carpeting, upholstery, and some dogs can have kind of a bleached out hair coat when you use it regularly. So the hypochlorous products like Vetricin and others that have gone onto the market, these are weak acids and they're pH balanced. The reactive oxygen species are produced as a oxidative burst and then kills the staph related to it. These are certainly more pH balanced than using Clorox bleach, but I don't personally find that they're as effective in my hands. A study done years ago by Tyler Endenberg didn't show very great efficacy compared to a placebo control. But again, clients come in and I want to say these products don't work. There are certainly cases that do respond favorably, but in my hands, not as effective as dilute Clorox bleach. This is a case of Dr. Parnell's, who's now in our San Diego office, but during her residency, this is a German Shepherd with a severe MRSA infection that had a good response to topical diluted bleach before and after. Notice the post-inflammatory hyperpigmentation. That's a common scenario, regardless of how you resolve the pyoderma. The hyperpigmentation is a common situation. As a rule, I try to sometimes simplify things for clients. How long do I have to leave the shampoo on? Well, if you time it, 6 minutes. If you're guesstimating, 10 minutes, because most people don't guesstimate accurately. And then rinse really well. Do you shampoo once a week and then use like sprays, mousses, wipes in between on off days? The SIVA people with their new Duxo line, they have lots of studies where they show bathe the dog once a week and, use the mousse twice a week, 3 times a week. So these protocols have been shown to have efficacy. And then in many of my cases, I'm doing bleach rinses either the same day as they're getting bathed with all the shampoo rinsed off and they're still wet, and they get bleach rinsed, and the bleach rinse dries on, or as you blow dry them, you do not rinse it off. Or they can do the bleach rinses without bathing, and they just do it on a daily basis, or they spot treat the dogs. I tell a lot of clients to apply the bleach before they take their dog for a walk, and by the time they're back, then we have the dogs that are dried. And so this is being done, for dogs with MRSA infections with and without antibiotics. So a couple of quick words about the environment. We actually have a full-time, janitorial service that wanders throughout the clinic all day long. They wipe doors, they wipe light switches, they wipe doorknobs, they disinfect everything. We wash our hands constantly. We know during the COVID outbreak, it really had a dramatic reduction of methicillin-resistant infections in human hospitals as well, because people were disinfecting their hands and we were being so careful about cleaning everything that MRSA dropped off in human hospitals. But again, wash your hands frequently. Use disinfectants. And I don't want to spill the beans. One of our residents, Dr. Kane, is completing a study actually using Purell as a topical product on dogs with methicillin-resistant staph infections. And again, that'll be out in publication sometime soon, but preliminary results are showing good favorable results. So besides a good hand disinfectant, it can be used topically. Take your lab coats home and wash them. Don't hang them up at the end of the day behind the door and put them back on the next day. The lab coats have been shown to harbor MRSA infection, so you could be a vector to spread it to some other patients as well. Wipe your stethoscopes off regularly. Disinfect your ear cones. Dr. Kirby from our office and Dr. Newton years ago did studies of quote unquote clean disinfected ear cones and cultured those and found that many of them are contaminated, especially some of the older ear cones that have more nooks and crannies in them. So make sure that you're doing proper disinfection on all the products. And lastly, only a few words on systemic therapy because we don't have lots of time, but systemic antimicrobial therapy, look, you're going to have selection factors that you use. Now, for example, if I look at this lesion, and let's say this is a MRSA infection, besides it being a MRSA infection, it's a deep, nasty infection. There's folliculitis, furunculosis, cellulitis, scarring. So I'm going to pick an antibiotic that's not only sensitive for methicillin-resistant staph, but I'm also going to look at the antibiotic's ability to concentrate and penetrate scar tissue. I'm going to look at dosages that are on the high end of the protocol, not the low end, because we need to get good tissue penetration. Is this a dog that's immune compromised because it's been on drugs that suppress the immune system? And then, of course, we have lots of client concerns because some of these drugs are going to be more costly. But we also know that client compliance goes up when we only have to do something once a day as opposed to 2 or 3 times a day. So are MRSA infections more difficult to treat than non-MRSA infections? Well, sometimes. Not necessarily if you use the right drugs. But remember what I talked about earlier is the need to make sure that we address the underlying primary disease, eliminate any immune suppressive drugs that could be contributing to relapses. Now, some of these drugs that we use for MRSA infections, such as amikacin and rifampin, these are drugs that require more monitoring, more expense, and so there's going to be a little more frustration with it. Some of our first round antibiotics that we might empirically reach for, or even based on a culture, doxycycline, trimethoprim sulfa, chloramphenicol, these are drugs that can work, that have potentially less side effects, but look, you can have liver side effects from doxycycline, you can cause dry eye, hypothyroidism, a polysystemic, sulfur immune-mediated disease, and chloramphenicol can cause liver problems. They can create a rear-end paresis problem. So there's a lot of different potential risks with all these drugs. And amikacin, of course, we mainly monitor for renal side effects, and rifampin, we monitor the liver. We generally try to avoid fluoroquinolones. So even if a culture suggests that it's sensitive, there's really sort of a high degree of fluoroquinolones kind of contributing, at least especially on human medicine, to the development of methicillin resistance. And so I try to avoid fluoroquinolones, even if a culture insensitivity suggests that it could be effective. That's not always, but that's one of my goals. And of course, geographic variability and resistance exists. And is it longer clearance time for staph infections? Not necessarily, especially if you use the right drugs. Here's one of our patients that had been on trimethoprim sulfa. We did a culture and then switched it over in chloramphenicol, and you can see a nice response within a couple of weeks. So again, cultures can have their value in helping us to isolate the correct drugs. So in closing, identify the underlying diseases. That's critical. Topical therapy emphasis for our methicillin-resistant infections. Make sure we use appropriate systemic therapy. And when there's dosage ranges, always go on the high end of the doses. Think about mutant prevention concentration cutoffs. By having higher serum levels, we're going to achieve that more readily. And again, identify and treat the infections. Utilize the culture sources that we have through traditional and the new next generation sequencing options to help us figure out more difficult infections, and just make smart choices. Wash your hands, wash your clothing, disinfect your stethoscope, your ear cones, all the things that we use on a day in and day out basis. So this is the QR code for the CE. So you could take your phone and register for that to get your 1 hour credit. And then I'm going to let Janina relay any questions for our remaining time.
Thank you so much, Dr. Rosenkrantz. That was a great presentation. We also have the link for the CE credit in the chat and in the Q&A. So in case the QR code doesn't work for you, you can just follow that link as well. We do have a couple of questions. The first one is coming from Dr. Tang. And the question is, besides Staphylococcus species, what other microbes do you see causing skin infections for dogs? And how frequently do you see them?
Yeah, so good question. So how often do we see other microbes other than staph? I mean, we see a lot of other microbes that are isolated, whether it's through MiDOG or traditional cultures, and it's not uncommon for us to grow things like strep, canis, for example, Pseudomonas, Klebsiella, E. coli, Proteus, Corynebacterium, Enterobacter. I can't give you a percentage that we see these with, but I would say that in general, it's not uncommon to see staph there with other bacteria joining in. Now, that's one of the reasons I like MiDOG, is that a lot of times I get a percentage of how much is staph playing a factor in that particular lesion. Is staph 90% of what we're seeing, and then we have 10% of other, potential pathogens. And some of the bugs that I just mentioned, they're there for the ride. Are they true pathogens? Are they overgrowth of normal, microbiome that changes in the face of staph infections? Things like Enterococcus and Corynebacterium sometimes are not necessarily viewed as primary pathogens, but they certainly can be.
Okay, thank you. The second question is, besides the pathogens themselves, what other factors can trigger or cause skin infections? Examples given here are diet, UV exposure, temperature, and more.
Yeah, there are a lot of other factors, that contribute to the skin infections. And as I mentioned, allergies is certainly the number one cause that we see in clinical referral practice, and that these dogs with allergic skin disease, particularly atopic dermatitis, they are self-traumatizing themselves. They have defective barrier function. They have alteration in their normal carriage of staph compared to non-allergic patients. So whether it's environmental allergies or dietary allergies, those can certainly precipitate things. We see a number of patients that come in that are on drugs to control their allergies, and drugs that suppress the immune system as part of the way that they function can also contribute and promote infection. So if you have an allergic patient, so you have the allergies contributing to the tendency for infection, but let's say that patient's on steroids or cyclosporin or oclocinanide. These are all drugs that function by suppressing the immune response, and these drugs can help promote infection as well. And then we see dogs with other non-allergic causes, dogs with endocrinopathies, dogs that have Cushing's disease, dogs that are hypothyroid. Solar damage, as I mentioned, is more of a chronic damage to the skin before that actually causes bacterial overgrowth. But there are many, many other underlying conditions that predispose dogs to infection.
Mhm. Do owners need to do any environmental decontamination at home to prevent reinfection? And what cleaning products are best for home use?
Yeah, so recontamination is a good question, and I don't think there's been good studies to really evaluate that. We know that since we can harbor MRSP on our clothing in our hands, then it's logical that a blanket or bedding could have it as a contaminating factor. And so one of the things that we recommend, particularly with bedding, is bleaching. So washing in hot water and making sure that bleach solution has been used in the washing of bedding is very, very important. If an animal, we can change, say, sheets out, can we lay areas that protect, say, the sofa or other areas, and these blankets and sheets can be washed on a frequent basis. That's probably one of the best ways of decontamination, especially with concurrent bleach added to the wash.
Mhm. Next question is, does MiDOG provide sensitivity information? And I can answer that one. Yes, we do, with a report that highlights 43 different antibiotics that are optional for the pathogens, and each of the pathogens detected in the report has their own antimicrobial resistance profile. Next question is, polymicrobial infections are quite common in NGS tests, as you mentioned, Dr. Rosenkrantz. Are there any research studies that show if polymicrobial infections are more problematic than monomicrobial infections? And do multiple species of bacteria work together to cause infections in a synergistic way?
Yeah, I mean, that's a great question. So I'm not sure that I can answer that entirely. I would say that in some of our immune compromised animals, it's not uncommon to see multiple different, pathogens. So I always try to look at, when I grow multiple different bugs on a culture, then I focus on what I believe to be, the most important of those multiple pathogens. And that, again, if you do a MiDOG, you get some information back on percentages, but a lot of times we're basing the number of bugs on our observation cytologically. So when you do a cytology prep, you can actually get a pretty good idea what is the predominant, bacteria that you're seeing cytologically. And in many of these, staph is still going to be the one that we focus on, especially when we grow a MRSP and we might grow other organisms at the same time. I'm going to sort of emphasize my antimicrobial selection on addressing the staph. Now, the question about, are other bugs and do they make the MRSP more pathogenic, more difficult to clear, or vice versa? Does the MRSP help set up an environment to allow other contaminant bacteria to grow more readily? I don't think anybody knows that answer. We do know, and as we're studying more, microbiome changes and in the normal versus abnormal animals, that there can be changes in the normal microbiome that happens in the presence of infection. And is that a protective mechanism? Is it an adaptive mechanism? I don't think all the answers are known on that.
Mhm. Rexel is asking, have there been any studies regarding clonal variants of MRSP based on the region? A lot of my patients with recurrent MDR pyoderma are becoming more resistant to mupirocin based on culture and MIC. Perhaps it's geographical resistance or just more patient resistance due to recurrence.
Yeah, I mean, again, another great question, looking at specific staphylocomal, chromosomal cassette mechagenes, are they varying? Of course, in human MRSP infections, they're isolating the specific mecha genes on some of these that may be more considered more contagious or more virulent. That hasn't been done to the same degree, to my knowledge, in regional areas. So I think, as a rule, when you look at countries like Norway or Sweden, where they hardly use systemic antibiotics at all, and they rely mainly on topicals, and not that this is still happening this day and age, but years ago, if a dog grew a MRSA infection, it might have been put to sleep or euthanized as opposed to dealing with it. But the lack of using widespread systemic antimicrobials definitely has a lower regional incidence of MRSA infections. In areas where we use antibiotics quite readily, like in Southern California, I think that definitely contributes to the development of further resistance. And that's where, good antibiotic selection and topical therapy comes to play.
Mm-hmm. Next question is, does MiDOG differentiate the pathogens from commensals in the report? Yes, they are being differentiated. Pathogens are always highlighted on the first page, and commensals are listed on the third page, just for the clinicians to know that the commensals are there. And sometimes even a commensal can turn pathogenic, so it can be quite important to know the balance of the overall microbiome. The next question is, how worried should we be of transmission of MRSA strain to other patients that are MSSP at the clinic?
Yeah, I mean, I think that transmission can happen. I don't want to give specific examples, but I can tell you that I was aware of one surgical specialty group where one of the doctors was a carrier for MRSA and had to be decontaminated because they were having a higher incidence of MRSA infections in their orthopedic patients. And so whether that's through nasal carriage, but you can screen, humans in the environment on whether they're carriers. Years ago, the American College of Veterinary Dermatology had the majority of the ACVD members participate and cultured themselves to see what the incidence was of MRSA in dermatologists. So we would be considered obviously a very susceptible group to being carriers because we're working around animals with pyodermas all the time. And there was, somewhere up to around, I think it was 12% of the diplomats that were sampled had tested positive, but they didn't have clinical disease. And I'd say that none of our dermatologists were in that positive group, but there were some throughout the U.S. that were carriers. And so there's no doubt that you have to be careful. I'm not saying that you need to be paranoid in your practice, but washing your hands, frequently in between patients is optimal. I don't always do that. I try to. I do, try to use disinfectants whenever possible.
Next question is, what are the risks of antibiotic resistance developing from topical therapy, for example, daily washing, sprays, and mousse versus intermittent systemic therapy? And we actually got an answer from Dr. Duclos, who said, good question, Annabelle. I wonder always about how much we're affecting the normal microbiota of the skin by topicals that kill all of the microbes. We have been using topical 70% ethyl alcohol frequently, and it does not seem to affect them. What are your thoughts, Dr. Rosenkrantz?
Yeah, I mean, I know the study, that the work that's being done in Dr. Duclos's practice, that's where Dr. Kane is at doing the Purell studies. And it was actually Dr. Duclos's idea to do a study because he's had great success using things like Purell as a topical for treatment of pyoderma and resistant staph in particular. There are studies now, and it is somewhat, frightening that there are resistant genes developing to chlorhexidine. So if you want to read about it, not to make you concerned and paranoid, but yes, resistance has been seen to chlorhexidine. So there are resistant genes that have been identified to chlorhexidine products topically. So there's no doubt that resistance can happen. We like to think that the resistance is relatively low. And certainly in proportion to systemic, antimicrobials, it's definitely lower than that. And I think I'd rather see resistance starting to happen maybe with some topicals as opposed to systemics. And there's lots of new products on the market. There's new things topically that are being evaluated, to help us treat staph infections on a topical basis. So it's a good question, and there is data to support that chlorhexidine resistance has been documented.
Mm-hmm. Yeah, Dr. Duclos had an additional comment saying, we also use a lot of Dakin's treatments, which also kills other bacteria, and that this needs to be considered. The next question is, does MiDOG also pursue sensitivities to yeast like Malassezia and Candida? And we currently do not. Predicting antimicrobial resistances of yeast is very difficult because of their life cycle. So for the moment, it's only covering resistances for bacteria. Dr. Rexer has another question saying that they are also seeing resistance to fluid acids in Europe. So more comment.
Fusidic acid, yes. Mm-hmm. Yeah.
There's another question asking, is the dilute bleach painful to raw and open lesions?
Surprisingly not. I showed you that one image in case of Dr. Parnell's, and you saw that dog actually had eroded ulcerative lesions. And surprisingly, most dogs don't object and act like they're in any pain or burning sensation. On some of the cases that have deeper ulcerative lesions, you could start at a much lower concentration, like the 1 to 32 dilution. And you can also, follow the recipe for Dankin solution. It's listed on, the internet. You just type in Dankin solution, and it will tell you how to add a buffering agent to it, the baking soda, so that there's, that it's more pH balanced.
And then there's another question focusing more on allergies. For allergic dogs, do you run specific IgE ELISA to assess binding capacity?
We do allergy test them in a lot of our patients. So those particularly middle to younger age dogs, we do a lot of allergy testing in our practices. We rely a lot on intradermal skin testing, but we do serum allergy testing as well. And we do feel that successful immunotherapy can not only minimize the pruritus control, but also the relapsing infections.
Another question, does MiDOG have a microbiologist and stuff? Yes, we actually have multiple PhD microbiologists. And I think that was actually the last question. So thank you very much, Dr. Rosenkrantz. That was a fantastic webinar. We hopefully can do it again sometime soon. And thank you everyone for joining us today. Have a great rest of your day. We will make a recording of the webinar available. And so keep an eye out for emails coming from us. Thank you.
Thank you. Have a good day. Bye.